So this presentation of a peer support service in Maine is what we're going to hear now, and I'll just read the bios, and you all can add more if there's anything else. So Randy Morrison is Director of Peer Services and came to direct Maine Behavioral Healthcare after working as a peer support specialist with people experiencing homelessness and other vulnerable life circumstances in the Portland, Maine area. Sarah Lynch is the program manager at the Portland Identification and Early Referral Program. She has been working in this field for over a decade and has championed early intervention work. And thirdly, Saras Yerlig was PIER's youth peer support partner for 2 years and is now the supervisor of the peer support staff. She supports many programmatic efforts such as the Speakers Bureau and young people. And turn it over to you all if you'll, just Casey, you'll take me off the screen, right? And yeah.
Thank you for that introduction. Thank you all for being here with us today. We're excited to talk with you about integrating peer support into a multidisciplinary team here in Portland, Maine, and specifically an early intervention program team. We were going to do some introductions of ourselves, but I think we have mostly been introduced very kindly. I'll just add that my pronouns are she, her, hers. And Randy, Sarah, do you want to add anything else to your introduction?
Just that I'm excited to be here with you all. I'm Sarah, and my pronouns are she, her, hers. And yeah, I've enjoyed being a participant at the ISPS conference over the last few years, and so it's fun to be here with you.
And yeah, as I'm Randy, I use he, him pronouns.
Did you want to add anything to introduce yourself there?
Oh, I guess I would just say I came on so I've been working at Maine Health or Maine Behavioral Healthcare for 6 years next month. So that's how long I've been working here, but in the field for about 10.
So brief overview of what we're going to talk about today. We're going to start out with an introduction to intentional peer support and what that looks like here in Maine. We're going to talk about the Department of Peer Services at Maine Health and kind of what that looks like, and then talk about integrating peer support into multidisciplinary teams in general, and then specifically what that looks like at the PIER peer program in Portland. Next slide.
So one of the places, I don't know how many folks are familiar with intentional peer support, but this is one of the places we'd like to start when we're having this conversation. And, you know, we really look at like that there's the word intentional is there for a reason, is that we come together to have mutually supportive relationships with the folks that we meet with. And that looks very different than a traditional service provider relationship. And so we provide that alternative way of being with people. And then that might even look differently than what we experienced in our friendships and our families. And so we talk about that and we acknowledge that. And a big part of that is like being able to have conversations where both of our needs matter. We both have space to, you know, talk and share about our lives. And we'll get into a little bit more about that.
So there are 3 principles, overarching principles in intentional peer support. The first one really looks at the process instead of one person being in the helper role where their purpose is to help the other person with their struggles. and it's really sort of one directional. Instead, the process is more about learning together. Both people have things to offer, have wisdom, and can learn from each other and can learn together throughout the course of the relationship. The second principle is really about the focus being on the relationship as opposed to on one individual. And so both people both people's needs are accounted for. They can negotiate together what they want the relationship to look like, how they want to spend their time. And then the third principle is it can be very easy when we've struggled a lot for there to be a lot of fear around, what is it going to look like if I feel that way again? What if I can't get better? And there can be a lot of focus on just the scariness of what it is to struggle. And instead of focusing on that, we try to hold on to hope and possibility for things being different and thinking about what we want in the future in our lives. Next slide.
And I think one thing I would say about that is an example of how that might come up is if someone, I think within interventional services, if someone says they're going off their medication, there can be a fear response of, well, you know what happened last time, you ended up in the hospital, you don't want that to happen again. Like there can be a fear-based response. And instead we try to come from a place of okay, it sounds like, where you're at with your medication isn't working for you. Like, what are you hoping for? Like, what are you thinking around this? Like what's been going on? And sort of, come from that place versus fear.
Thank you, Randy. So those are the overarching principles. And then we have 4 tasks as well that we really keep in mind as we form relationships with people. The first task is about connection. We always have to start with connection. What that looks like is validating, being curious, being vulnerable as a way to get to know each other. And once there's a good connection established, we can really start to explore worldview. What that looks like is trying to understand better, what's happened to us in our lives and how that shapes how we perceive the world today and what we want from the world in the future. Really taking a look at that, and that can be a very healing process to better understand why we might feel things that we do or make sense of the world how we do today. And that can really help to build connection with the other person when we understand what their worldview is. The third task is around mutuality. So this goes back to the emphasis being on the relationship and both people being able to be transparent and being able to talk about if there's a power dynamic, one person's being paid, the other person might not be. What sort of things did that bring up? And really being able to share that power as much as possible and negotiate what the relationship looks like. And really both people having that opportunity rather than one person kind of guiding it or shaping it. And the fourth task is about moving forward instead of moving away from. So instead of the energy being on, I just don't want to feel that way anymore. Instead, the energy can be towards, I want to feel this way. Like I want my life to look like this. And being able to focus on that really sort of, I think, can pull the energy up and open up possibilities. So those are the 4 tasks. Randy, did you want to add anything else to that?
Yeah. So I think this is these 2 slides go together. When we think about traditional helper role, like me as that traditional helper, when someone that I go to support, it's really one directional. Like you come, you tell your problem story, and I help you navigate that problem story, and we really center you in that relationship, and it's one directional. In peer support or intentional peer support, we really shift both of our focuses, shift to the relationship and how can we both, we have a shared responsibility to really care for the relationship that, as we talked about, we both matter in this. And so when things aren't working for one of us, they're not working. And so we need to talk about that. It also shifts from this constant problem focus to more of what Saras was just talking about of what do we want to create together? What does a relationship that works look like? And how can we support each other in navigating that and have transparent conversations around that? So by shifting that focus, it really creates new opportunities to talk about how we exist in relationships and what our hopes are with our time together. So for folks who aren't familiar, so Maine is, had in 2003, 2004, a stakeholders group come together with people with like lived experience who worked with Sherry Mead, who is the sort of creator, author, holder of intentional peer support. And they worked together to sort of flush out a certification program in Maine around intentional peer support. And they first piloted that in 2006. And since then, Maine has used that program, intentional peer support. It's called a certified intentional peer support specialist, is what's used for all of our Maine Care, Medicaid, Medicare billing programs, grants related to mental health are all centered on intentional peer support. And so there's no cost. The state holds that program and they fund it, and there's no cost to participants. And IPSAC is the Intentional Peer Support Advisory Committee. And that's a group of people who are certified in intentional peer support. And they sort of talk about the challenges in the community of Maine, and how the program needs to adapt, or in reviews applications for the program and all of those sorts of things. And so it's a unique sort of setup in Maine that really centers intentional peer support. And it was built from the consumer movement, or ex-patient, people with lived experience.
We really value the way that this is set up, because there's a lot of benefits to having a concrete, robust model that's present throughout the state that everybody's trained in and is consistent. And that offers ability to collaborate. It offers like a general understanding of what peer support is and what it looks like. And it offers opportunity to have professional development and growth, and share supervision and mutual learning. It also helps, I think, us stay grounded in the social justice, disability rights, like history, background, roots of the movement, because we have such a strong model that we're all trained in and that we all kind of come back to as we're practicing this work. And I think also having this model allows for the peer support role really to stay intact, even when it's integrated into part of the system that was created to push back against, and allows for people to really hold true to the model and sort of resist co-optation by the system. And it's really created clarity and consistency, which is really important when we're articulating about our work and explaining it to everybody.
Yeah, absolutely. And so we wanted to just offer this to give you a sense of the scope of the work that we do. It's probably a little bit small on your screen, but it's sort of across here, if you can see my mouse, across the widest row are all the different peer support programs that we have. And so in our sort of structure, every peer support specialist, whether they work in substance youth peer support, our parent or family peer support, if I haven't said this yet, substance use recovery peer support, or primarily like traditional mental health settings, like PIER, like we're going to talk about. Every peer support role has a supervisor that's a peer support supervisor, a person who everyone has been a peer support specialist themselves, so they've done the work or are trained in the work and have lived experience. And so we don't have clinical oversight, or clinical ladder in terms of who oversees our programming. It's all within peer support, even within a very medicalized traditional mental health service and healthcare system. We're the largest healthcare system in the state of Maine. We have a number of hospitals and offshoots. And so even within that, really clinicalized structure, we have, a peer support department, and we oversee and directly supervise everyone. And we'll talk a little bit more about that. But we have, folks working in emergency departments and substance use treatment programs. We have a statewide youth network. We have peer support centers, which are like community centers in 3 communities. We have behavioral health homes, or a case management program, and those are in a number of locations as are listed. And so our staff is about over 50 people right now. of peer support work across, all of these services. And so a big part of, one of the benefits of having, a sort of quote unquote department, is that we get to really focus on the culture and how we want this work to look like. And so that involves like really focusing on, I think every new person we have on our team, it's like, these roles are learning and growth roles. We, don't expect folks to come in as the experts in peer support. We're here all learning together, including people in leadership roles within our program. And so that is a really important focus, that we're all, in this together to sort of navigate this in a way that we're constantly adapting to make sure that we're holding fidelity to peer support. And we also focus a lot on providing ongoing training and opportunities for folks to get support, which can include the sort of role plays sessions that we do every week. We have group facilitation support, and that's all facilitated by and the people who come are peer support staff. And we work on a variety of like anti-racism, gender affirmation, or gender inclusive, care work, both within our team and with a larger system. We helped fund a committee and some training around gender affirming care for traditional providers. And so we do see that sort of work internally within our team, as well as looking at the larger system and how we can help support and guide that to be more inclusive and more patient-centered or person-centered. And Sarah.
So thanks. Sorry, I just realized my volume wasn't on. So I'm going to talk a little bit about the early intervention program called the PIER program that works with young people age 14 to 26 that are within a first year of a first episode, or that we have a couple of programs within our within Maine Health, one is within 1 year and one is within 2 years. And we're also working with people who are at clinical high risk for psychosis. PIER has been around for about 20 years as a research and treatment program. And we continue to have a component of research and training as part of the program. And we're sort of working towards a statewide offering. Currently, we at PIER are doing a statewide service through telehealth, but we are next year going to have a bundled rate through Medicaid, so that people across the state will be able to take advantage of this. And we hope to have other sites around the state emerging when we have that ability to be a sustainable program. And I've been part of both the PIER program and the PIER Training Institute, which is national. Next slide. So we use a coordinated specialty care model, similar to a lot of other early psychosis programs across the country. And peer support is a key component of the model. And it's been incredibly exciting to see what Randy has been building in terms of peer services across our system in the time that we have been around. Do I see a hand? Is somebody raising a hand, or did you?
Yep, I see a hand. Kermit and Louisa, is that right?
Yeah, Kermit, did you have a question?
That was my hand taking a screenshot of your slide.
Oh, okay.
Sorry. I'm figuring out how to do it now unobtrusively.
Okay. So the other parts of the coordinated model are multifamily group and family support, which I'll talk a little bit about in the next slide. Individual counseling, care coordination, psychiatric consultation and medication management, and supported education and employment. And a key component of what we've been doing all right along is community outreach and education to identify people younger and at the earliest stages to hopefully avoid a hospitalization. We've been working with primary care, schools, and mental health professionals and community providers to get the word out about early intervention. Next slide. So I want to just talk about the history a little bit of adding peer support to the PIER program, because I would say that PIER has its roots in community education, which I just talked about, and team-based care. But interestingly, the multifamily group model, we've had peer and family support kind of emerge through that model, because we bring young people and families together with one another, and we've been doing that for a long time. And I would say that we've had a lot of experience of young people and family members wanting to stay involved and come and continue to come back and speak to new families coming in. But it was very informal, and we were trying to do kind of some of the things we're now able to do with Saras on board and really leading the charge of staying engaged with our young people. And we're doing the same thing with the parents. So currently, at first we tried adding peer support through an outside agency, and it was just challenging because it was sort of fragmented, and we were trying to connect people to peer support, but the linkage wasn't really happening. And it is so entirely different having peer support be within the organization, and having, the peer is able to have a separate role, but also be really well integrated into our team. And there's just a lot of coordination and engagement with all team members, which helps the young people and families to get engaged. And then the research alongside our program, our researcher, Kristen Woodbury, is interested in pathways to care and parent and peer support as initial engagement, and also interested in sort of primary care and getting people into treatment earlier through the support of peer and parents. Next slide. So just a couple things with COVID. I think we've sort of catapulted into Zoom, and it's allowed us to do some things differently and offer some ways for people to engage in hearing, in attending a monthly community education workshop, and also hearing a panel of graduates to our program, which is our workshop is on our website, and people can, anyone can tune into that. And then we've been offering weekly Zoom groups for prospective and current clients and families, which has been a nice way for parents and young people to just meet other people that, and learn more about the experience of being in the program. And then we've also been able to offer just a one-on-one connection between, program graduates and a peer support specialist, or a graduate parent with a parent that's, waiting or has questions about the program. The multifamily group model, as I said, is there's peer support. The peer support specialists are embedded in the multifamily group model, and it's co-led between the various roles on the team. So employment specialist, case manager, clinician, peer support. We have different perspectives in the room alongside the young people and families. So, and all co-facilitators are group members and share their own lived experience as well. And group members experience, it's just nice to have a balance of, it's a very structured problem-solving model, and we do problem solvings for family members just as much as we do for young people. So there's just a real community feel and stigma reduction. So you can, excuse me?
Yeah, just a quick time check, Sarah. We'll have to sort of be thoughtful about that. So we have time
okay,
for
yeah.
questions.
So I was just gonna say, go to next slide, and this is just a visual of what I was just saying, which is basically that the graduates of the program, that become part of the Speakers Bureau and Advisory Council, and research sort of feedback into the community outreach that leads to people engaging in the program. So there's just to sort of show the connection between the peer and family experience to the program success. Next slide.
You can skip this slide, Randy. I think we touch on it later. This is an example of a schedule of a peer support staff at the PIER program. As you can see, there's things that might be intuitive, such as one-on-one meetings and groups, being part of a team meeting. There's also some other projects and ways of being involved. And I think having a really dynamic work schedule and job description really helps to expand the work. It helps to feel motivated and feel fulfilled. And I think it helps to have lots of different ways of growing. So I think thinking about creating a peer support position that's dynamic is important. Next slide. We offer 2 different groups. We collaborate with peer support staff at a number of different programs. As Randy outlined, Maine Behavioral Healthcare has a number of different programs that have peer support. And we find it's beneficial to collaborate between programs. It allows for just like sharing the burden of like running groups. And it also allows for learning from each other, and also allows for participants that might graduate one program and enter another program to have some continuity because they may already know one of the staff members through the group. One of our groups for adults called Exploring Unique Experiences, and it's structured off of the Hearing Voices Network and Alternatives to Suicide facilitator trainings. If you're not familiar with those, I suggest taking a look. You can find websites on them. They're really excellent peer support philosophies that guide that group. And the other group we have is for high school age, and that's a little bit more around bonding and fun and check-ins. And we created some group norms for that all together. So trying to kind of have the group be led as much by the people, the high schoolers that are part of it, as by the peer support staff that run the group. Next slide.
So, so when we're thinking of, so you have a sense of how PIER operates, you have a sense of the peer support program. And so how do we really blend those two? And so we're going to talk about these different things around supervision, team meetings, et cetera. But one of the things that we often need to talk about is that, it's not just adding a peer support person to your team and then you just keep operating the way that you've always operated. We think it's really important to think thoughtfully about how you maintain the fidelity of peer support work within clinical settings or multidisciplinary teams. And so we're going to talk a little bit about what that looked like. So for us, as I've already mentioned, every peer support person is supervised. Their direct supervisor is a peer support supervisor or manager. And that's illustrated by the solid line between the peer support staff and the peer services manager. But there's also a dotted line to the program manager like Sarah, because they have a really important role in ensuring that there's a smooth operation of the team. And so they're really a core element of that. And they can really, whether they're supportive and of peer support, really determines if we can be successful in this work or not. And so that relationship is really important. And so that sort of as a supervision model looks like one-on-one supervision as the frequency as needed for the peer support staff. And then we also have at least a monthly meeting between the peer support staff, the peer supervisor, and the local program manager of the team. And that allows us to sort of talk about how things are going, how are referrals moving, how's communication looking, how are requests looking, how's team dynamics looking, and really sort of explore all of that with an eye towards maintaining the integrity of the peer support role and ensuring that the program has what it needs as well. Our team also offers a monthly peer support meeting for all peer support staff to come together and learn and have some training and support each other and build community, which is really important. And I've talked a little bit about the role plays. And one other feature we have is a coworker mutual support partners, or like a buddy system where folks in different programs in peer support can meet up monthly or at a frequency that works for them. And they get to really learn about each other's programs. And it's another level of support. We don't want the supervisor to be someone's only support. And so we really focus on creating a community for folks to go to 3 or 4 other people. It doesn't have to be their supervisor. We're all on the same model. We all have the same intention. And so they have a real community of people to support them. Folks, shouldn't work in isolation and peer support. It's just really a problematic dynamic that we do see at smaller agencies. So, I've touched on these. There's a really important role of the program manager, but the person who primarily has conversations around performance and expectations is the peer supervisor. And we really try to be adaptive to the individual's needs. And so I worked, really closely with Sarah in integrating peer support in their program. And so, that relationship has been important as we think through some of these other elements. Sarah, was there anything around this that you wanted to speak to in terms of the way that supervision is set up?
No, I think you can go ahead and we can always address questions at the end.
Okay. The other piece is the team meetings are quite important. They typically always need to be redesigned. Our peer support staff leave during clinical discussions. And so they don't participate in those by design. Often the person who is a client of the program is not present, and so the peer support is not present either. We want that relationship, the integrity of that relationship to be maintained, that the peer support staff is not hearing about the individual they're meeting with outside of directly from the person they're meeting with. And so that can really shift the power in the relationship and create a shift in the dynamic. And we want to really, again, hold that integrity of that relationship, that what the peer support learns about the person is from them directly. There's always space in the agenda for peer support staff. They are there for part of the team meeting. And so it's important that there's space for them in the agenda. And we'll get in a little more about what kind of communication happens in a minute. Okay. And so talking about communication, certainly we think it's okay to share like logistical information, like who are you meeting, when, where are you going to be, who are you connected with, sort of any sort of administrative topics, the sort of status of the relationships, like, oh, I haven't been able to get a hold of this person or not. That's just good logistical, or what we would call logistical information. And it's always good to share. And that really helps the program understand what engagement looks like in peer support. You know, and then when we talk about sort of okay information to share, that's more of like, you know, Sarah might, or a team member might go up to the peer support staff and say like, hey, you might want to give Janet a call. But we really are mindful of details. We would never say, oh, Janet said this, or Janet's going through this and you should call her. It's just like, hey, just give Janet a call. She might be having a hard time. It should be nice to hear from you. And those sorts of things are okay when we're being mindful. What we definitely avoid sharing and never share is clinical details between the peer support staff and their team, test results, medication information, assessments, how a client of the program, you know, made out on some assessment. We just don't share that information with the peer support staff. Again, we want their relationship to be unique and the integrity of it to stay the same and not be influenced by messages they're getting from the team. And so that is something that we really hold true as well. What that requires, though, is that a culture that sometimes people are going to share too much, and then that's okay too. Like, you know, we could check in about that. We want to welcome uncomfortable conversations of saying like, hey, you know, you shared this with me, it didn't sit well, it doesn't feel like it fits with my role. Like, let's check that out, and not from a defensive place, but just like, hey, we're all in this together, we're all learning, we're all setting these dynamics together, we'll figure it out. And so really sort of collaborative. And you must have that dynamic, otherwise it could get really tense and people stop communicating altogether for fear that they might be stepping on someone's toes. And you don't want that. So creating that culture that really welcomes uncomfortable conversations is important. This is just an example of what a team, the PIER team schedule looks like, what they might do sort of periodically during this time, and then from 10 to 11, that's when the peer support person leaves. Anything on this, Saras or Sarah?
No, I would say go ahead. I was just going to say that, well, that's just what I was going to say, thematic discussion. So go ahead.
Yeah, do this one.
No, I was just going to say that it's an interesting thing emerged on our team because we never have enough time. Everybody loves connecting with the peer support specialist. And then there's just a challenge of time. And one of our interns, together with Saras, like created a lunchtime kind of thematic discussion upon Saras's recommendation that allows everyone on the team, including, you know, interns, different, you know, employment specialists, case manager, clinicians, and peer support to talk in more general terms about just like ethical issues or challenges in the work we're doing, you know, so being able to connect with each other and not about a specific, in a specific situation, but more in general. And so that's kind of exciting.
Is there anything around this, Saras, that you'd like to talk
You
about?
you can go on to the next slide. Or if you wanted to add anything to that.
Yeah, no. So another part of like building that team cohesion, right? So a lot of team cohesion is often built and thinking about what a clinical team might describe as like a case, like, oh, we're going to do a case review. We're going to talk about a certain case, you know, individual, and you get to know each other and get ideas and share ideas. And that's a way to build a team. That's what we see a lot in traditional settings. And that doesn't happen with the peer support person. And so there can feel like this disconnect. And so, that's why we're talking about thematic discussions, which is like a de-identified way of having conversations around shared challenges and concerns. And how we are thoughtful of like how you include peer support in team meetings, that there is space for them. There is a check-ins and human check-ins of like, how are you arriving today, where we get to know each other. And another place to do that is within trainings, and that, opportunity. Some of our programs do it quarterly, where there's like a task of peer support that the team gets a training on. I've done a training for PIER on like intentional peer support, like a 2-day training. And that really creates opportunities for conversation. The team learns about this role that's a bit unique, and why we structure things the way that we do. And also opportunities to sort of get to know each other, share ideas. And so training is a really important piece of both team cohesion and ensuring like everyone understands why we're making the effort to shift up team meeting, why we're talking differently with the peer support staff, that it's rooted in a common understanding of why, and so that there isn't that othering, there isn't that resentment and there isn't that sort of disconnect between the peer support person and their team. And so that can be really important, as well as within larger trainings, maybe not within PIER, but like in some of our case management programs, they're in 10 communities. And so they'll do an annual statewide training, and there'll be a portion of that training that's dedicated to peer support as well.
Yeah, just to emphasize that we do cross training with everybody across all the roles on the team, so that everybody gets a feel for the importance of the work that each other is doing. And I think it helps us to support engagement with other aspects of the program.
Documentation is necessary, whether a program, whether peer support is a billable service as part of a program, or whether it's grant funded. There's usually a need to track engagement, and we do that in our electronic medical record. And we've had to be really thoughtful about how we document, how we write notes, because we really want to ensure that the integrity of the peer support relationship remains intact. That means that we're not reporting or writing down the content of our conversations. We're really just reporting that they happened and the sort of general nature of the conversation. So here are a few examples. We validated one another's recent experiences. We explored some recent challenges and supported one another through them. This is a way of acknowledging the type of conversation that we're having without divulging any of the content. And I think that's really important that we set it up that way. Randy did a lot of good work to make that happen.
Yeah, because I mean, I think if you take all the care within the team's communication about not divulging, information and clinical information and details, and then you go in and document all of those things, in a real detail, you've sort of undermined that intention. And so I think that's why, as Sarah's talked about, felt this was a really important, to come up with ways to document this work that held true to the values of peer support.
Another thing I forgot to mention is we are transparent with the folks that we work with, that we are documenting, we are writing a note and what that looks like, and ask if they would like to have us write anything in particular, explain a few of the examples, see if they resonate with the person, and that can be an ongoing conversation, but we're really transparent about that, so they understand that something is going into their medical record and they can have a say on what's in there on their record, because it's their record.
Yeah, that's great. Yeah.
Next slide.
So we just wanted to leave you with these 7 peer involvement self-assessment questions. Nev Jones has been a real leader in PIER involvement in early intervention programs, early intervention in psychosis programs, and really challenging people to think about, just financial compensation and pathway to growth within the job, engagement in other aspects in program development and in research. And I really like these questions. And I think that Randy and his team have really thought a lot about these questions within our system, and it makes a huge difference to how I think to people feeling like they want to stay and work in a place that really values peer support and sees growth opportunities within the role. And so, it's exciting to have, we just met as a group to talk about research development and, thinking about, intersecting projects and looking at pathways to care together. And so it's been, it's just exciting to have such a rich, such rich discussions happening across disciplines.
So to quickly sort of summarize, I think what the care that we've taken in terms of how we've structured supervision, how we think about team meetings, how we think about team cohesion, what trainings that folks can need, both within the peer support program as well as within the multidisciplinary team, has all allowed us, I think, because this is all challenging work and it never goes perfectly, but it's helped promote role clarity. It's helped increase communication between team members versus decreasing it. It really has helped around that team cohesion and satisfaction that we were just talking about. And ultimately, by being thoughtful and retaining the unique role of a peer support and holding true to that fidelity of that work, that now allows the peer support to have the, fully realize the potential of why this work is so important, and improves outcomes for people in their lives and creates another possibility for them and how they can navigate the world. And generally that improves outcomes across, these multidisciplinary teams, which is, sort of why we're doing this work, is to impact people's lives, to have them be able to navigate the world in a way that works for them and access the resources they need and the support they need in the ways that they need it. And so I think taking this care for us and trial and error has really allowed us to realize some of those benefits.
And our latest peer support hire was a graduate of our program, and had stayed engaged with Saras in a speakers bureau, and which led to interest in the role of peer support, which is awesome.
Yeah, and I think we've also had folks who have been in programs across other parts of our agency who have also then become staff members. We have folks that are in leadership who have been receiving services. Some of them still receive services, and so our agency has been really flexible to allow current clients to work here. Where some folks have just shut that down in other agencies, and so it's been important. Any final thoughts, Saras?
No. Thank you so much, everybody. I think we can take some questions. I'm really impressed with us that we got through all of our material and have time for questions. This is excellent. So go ahead and raise your hand or just unmute yourself. Oh, we have a question in the chat here. This is more of a theoretical question. I wonder if you have any thoughts on it. How can someone participate in peer support without being a peer support specialist? For example, if they plan on becoming a therapist, how can they access and become part of the movement towards valuing lived experience as expertise? That's a great question. That feels like a big question. Randy, or Sarah, do you want to start out responding to that?
I just want to understand how can someone participate in peer support without being in a role of peer support specialist? Got you. Yeah. Well, I know I think that we have had some interesting things emerging with both young people and families wanting to be involved in peer support, but not in but more in kind of like a volunteer way and a connecting, either speaking to other people one-on-one, or, but not officially in the roles. I think that's a great question. And I wondered if Saras or Randy seems to be frozen. Is he? Or am I?
It looks frozen on my end as well.
Do you have thoughts, Saras?
I mean, a few things jump to mind. If you're wanting to sort of get a little more exposure or knowledge around, peer support in general or the model, there are lots of like online support groups. You could also look and see where you live if there are any sort of trainings, if you're, even just a shorter training, if you weren't interested in going through like a full training and becoming certified. You could also see if there's any sort of peer support center where you are. That can be a great way to sort of informally meet people and learn about the approach and support people and be supported in that same way, just like as a community member. In terms of starting a program, that's probably something Randy could speak to a lot better than me, since he really grew our program from the ground up. But I think there's definitely ways to incorporate, if you were to become a therapist, to incorporate some of these values and approaches into clinical work. And there are lots of people that are doing that out there, and definitely like worth thinking about and having more conversations. I'd be happy to, our contact information is in the slide, but I'd be happy to talk more or put you in touch with somebody as well.
That there are some really great groups. I mean, I'm more familiar with, like in the early psychosis world, there's a organization called PEPNet that's national, and there's like a peer support group of people around the country that are doing peer support that come together. And so there are definitely, and I can give you that link, or Saras can, but there's ways to kind of connect with what other states are doing, that I think, are other ways just to find out about, like, PEPNet will announce a lot of webinars or trainings and things like that too. In terms of, part of our program has been mental health block grant funded, and we've worked, and I think a lot of other states are trying to figure this out, how to pay for this service. Yeah. And we do track, prior to coming into the program, ED visits, crisis stabilization units, hospitalization days. And then, while we're a 2-year program, I mean, it's a little flexible on that because some people stay longer than that and some people less than that, but our average stay in our program is 1 year. We are capturing that data, and it's hard because we don't know, we don't have, I mean, we've looked at some state data to have somewhat of a comparison group, but we do track that. We also track employment and education engagement on a quarterly basis. We use REDCap as a database that, and like an online system, and we use that alongside of our, I mean, we've just started with a new electronic medical record. And so we're trying to gather, you know, engagement in all aspects of the program through
Right.
through Epic, and sort of pair it with some of the data that we keep in.
Mhm.
I know Randy also is gathering data as well
Mhm.
across the peer services engagement.
I don't know if we're going to get cut suddenly. But I did just want to say, I think it's just so interesting how different programs, I mean, there's a number of things that need to be happen and how different programs do them. And I'd be interested, I probably don't have time now, but in the keynote tomorrow by Jaakko Sekula on open dialogue is a different way of incorporating all the staff, including peers, just be interesting to compare and contrast that model with your model of how you try and set those boundaries between the peer staff and the rest of the team around those, specifically around the clinical issues.
Yeah, and just to say a little something about that, they're not mutually exclusive in that, you know, some programs are doing a program that I trained out in California is doing both. I mean, they have like 10 multifamily groups, and they're also doing open dialogue with a subset of their families. So, you know, so it is interesting to think about, you know, I mean, I think it's these things can sort of coexist.
What is that California program?
It's called First Hope. And I think it's First Hope it might be firsthope.org.
Yeah, I mean, I think from what I know about, you know, open dialogue and the readings I've done about it, you know, they can coexist. I mean, the big part of why we structure the peer support role this way in terms of like sharing clinical information is that more often than not, the patient or client of the program is not present, right? And a component of open dialogue is that the person receiving services is present for all conversations about them. And so in which case the peer support person and the patient of the program can talk about like, hey, this meeting's coming up. What feels right for you for my involvement in this? Would you like me there? Are there things that you want me to share, not things you don't want me to share? So there's some pre-work that has to happen. I think what I want to avoid, even in an open dialogue kind of dynamic where everyone is present and talking, it's that the peer support person doesn't shift into some sort of expert role about the person, you know, about the patient, right? So they're out there saying like, well, I met with Josie and she expressed this to me, so I think that she needs this, but instead can be a support for Josie to think about how she wants to engage with the team and what her treatment might look like. And the peer support person with the team present can hear about how they might support that process. So I think even within an open dialogue that can all happen. The peer support staff can hear clinical information, but we just still do it thoughtfully, and we don't shift into an expert role about the patient of the program.
Everyone for coming.
Thank you.
Thank you everybody so much.
Thank you. Bye.